Hello and welcome to Lynchburg Live. I'm your host, Linda Smith. As we continue to observe Breast Cancer Awareness Month, my guest again tonight for part 2 of this series on breast reconstruction is Dr. Tim Silvester. Dr. Silvester, welcome back to Lynchburg Live.
Well, thank you for having me.
And I want to give you an opportunity to introduce to my audience the rest of the guys who are in your office with you.
Be happy to do that. I think they have a picture here. When Linda asked one of the doctors to come, she asked for the doctor with the most gray hair, and so hands down, I won that. But starting from left to right are my young partners, Dr. Keith Pitzer, the distinguished gentleman next is myself, Dr. Simon Hatton is next to me, and Dr. Henry Wilson is on the far right.
That's cool.
And they're all board certified plastic surgeons.
I'm glad to know who they are. I want to start out by asking you a question that probably nobody in the general public considers a whole lot. But I want to know how much smoking, what kind of effect smoking has on breast reconstruction.
Sure. And it's not only on breast reconstruction, it's on most any type of surgery,
right,
particularly when we're doing what we refer to as flap surgery. In a flap surgery, you are detaching at least part of the blood supply, and of course you must maintain part of the blood supply to keep it alive.
Right.
And in some cases, like we spoke about last week about what we refer to as pedicle flaps, there's only one main artery and vein that keeps that tissue alive. Patients who are cigarette smokers are at much greater risk of problems with healing or even failure of a flap than non-smokers. Nicotine is an extremely potent constrictor of blood vessels.
Right. And
there are a significant number of physicians who would not do certain types of these procedures in people who are cigarette smokers. No one would probably do a pedicled tram flap that we talked about last week in someone who's a cigarette smoker. Even what are referred to as the free flaps that are detached and reattached are at greater risk in people who are cigarette smokers. So if someone is a cigarette smoker, we try to strongly encourage them, or they have to actually commit to stopping smoking for several weeks before and several weeks after, or it really would jeopardize the outcome of their surgery.
And if you can do it for several weeks, then you ought to be able to do it.
Exactly.
All right. We're going to talk about breast reconstruction with implants, which is that the most popular method?
Historically, and by historically, I've been doing this for about 30 years, we certainly did more breast reconstruction with implants. We would refer to that as reconstruction with available tissue. We would be using all the patient's own tissue rather than importing tissue from another part of the body. Over time, it has been my experience that more patients are receiving radiation therapy, and it precludes this group from certain types of tissue expansion.
Right.
In a long-winded way, it is my understanding, too, that still using implants or tissue expansion is still probably the most commonly performed breast reconstructive procedure.
Do you think that the fact that some women just want to go on and get it done and get it over with as quickly as possible, do you think that factors into it, or?
Well, I think that, and when you explain to patients and show them diagrams, because education of the patient is very important. It's important that patients know what they're getting into, how many surgical procedures, the length of the procedure, hospitalization, recovery. They take an active role in making the decision. The tissue expansion technique is a less complicated, less involved procedure, and I think, generally speaking, can be carried out in a shorter period of time. So I think there are any number of patients who would choose that route for the reason you mentioned, that it can be done in a more expeditious, more rapid fashion with a less involved surgical procedure.
Now, Gelfilled, the Gelfilled implants, we hear so much about that on television. Gel comes out, it goes up into your nose, it goes down into your feet and causes problems. Is that still a concern?
Well, yes and no, in this sense. Probably for the first 15 years of my practice, we used primarily gel-filled implants. And then people who are even younger than I am recall when the FDA withdrew them from the market. We were not allowed to use gel implants except in very special conditions. So for about 12 years we used only saline implants, or primarily saline. Now for the last 2.5 years or so, the gels have been reintroduced. And there's a great deal of debate of whether they were ever a problem or there were other issues, political, financial, legal. But gels and saline implants are available. They are both offered to most patients. In some cases, we feel that a gel may be preferable to saline, and saline may be preferable to gel. I've had the perspective of using both of these implants for about 15 years, and to a large extent, I explain to patients what I think are the pros and cons of each and let them make the decision about what to use. I know my younger partners seem to be more in favor of the gel implants as producing a more natural consistency or feel to the breast, and not having one of the problems we potentially can have with saline, and that is called rippling of the breast. But there are advantages and disadvantages to both types of implants.
Do you feel that one's safer than the other?
The data today would support that neither implant is likely to induce other types of benign or malignant disease or autoimmune disease. A concern that I still have is the possibility of what is referred to as gel bleed. The older implants, over time, some of the gel would migrate through the envelope that is also silicone. The newer implants now have a thicker capsule that is supposed to significantly reduce gel bleed, and secondly, the gel is more cohesive. In years gone by, when you'd cut an implant, the gel could literally leak out like a very thick syrup. The newer gels are more of a gummy bear consistency, not quite as dense as a gummy bear, but if you take the implant, cut it in half and squeeze it, it'll bulge out and then come back, so it doesn't leak or run like a thick syrup would do.
What do you see as advantages over the flap procedures?
Well, the advantages are that you don't have the big surgical procedure, and particularly in women who have not had radiation therapy. It can be done more rapidly. They're less. It's a less involved surgical procedures. Patients who have had certain types of abdominal surgery, patients who have had a tummy tuck before, are not candidates for tram flap. Yeah. Tram stands for transverse rectus abdominis myocutaneous flap, and that's why we call it tram flap, because it's a mouthful. Patients who have had certain types of abdominal surgery that may have divided the blood supply to this flap would not be candidates. Certain types of body habitus are not good candidates for the muscle flaps, and we'd recommend then tissue expansion surgery.
Right, I've got lots of other questions, but I don't want to miss out on you showing these implants.
Sure.
So
do we want to look at the diagrams that we have about tissue expansion? I think we have some just basic diagrams. And what this diagram shows, the furthest to the left, just shows a chest wall where a breast has been removed, and the light color, I guess tan color, is basically the skin and subcutaneous tissue. Below that we see the, I guess it's more of a reddish color, and that's the muscle. The second picture actually shows what looks like a small implant. The blue is an implant filled with either saline or with gel, and we use what's called a tissue expander. It is an implant that can be placed, and then it can gradually be inflated or blown up with sterile saline to stretch the skin and muscle. I always would use the example of a woman's abdomen during pregnancy, that we know we can stretch skin and muscle to a tremendous degree, but it's hard to do it all at once. So with this technique, you put in basically something similar to a balloon, and then over time inflate it, maybe at weekly or every 2-week intervals, to stretch the muscle and the skin, and then put a permanent implant in place.
Now, is this tissue expander, is that put in at the time of surgery?
It can be. In patients who are having what are referred to as immediate reconstruction, the tissue expander can be placed at the time of surgery. You generally would like to have be reasonably assured that you're not going to radiate that patient.
Right.
And so in patients who are less likely to be radiated, you'd probably be more likely to consider immediate reconstruction.
What approximately is a recovery time following? Following the initial procedure when the expander is put in.
Right. When we do tissue expansion as a delayed procedure, meaning a woman who's had a mastectomy might wait 2 months, 3 months, again depending if they're having chemo, etc. The tissue expander can be placed generally it's done as an outpatient procedure performed under general anesthetic, meaning patients go to the hospital, they have surgery, they go home the same day. Patients are sore. We suggest they not do anything vigorous or strenuous for 10 days or so. Most people can return to what I refer to as a desk-type job in a week or so after that surgery.
What kind of incision is required in this procedure you just talked about when you go back and have the expander put in?
Generally reuse a portion of the mastectomy scar.
Okay.
In that incision to place an expander, and I can show you an expander if you would like to see one here. This is a tissue expander. I'm not sure if I'm holding it up so it can be seen, but this little device here is what's referred to as the port. And this is placed in the patient. There's a little metal cup inside the port, and we actually have what is referred to as a finder. And it actually looks like what used to be used to find studs in a wall that had nails in them, and there's a little magnet in it, and it actually will point to this. And thin people, you can feel it. But what we do, we place this device, and it can be placed through about a 5-centimeter incision, about 2 inches. Then patients come to see us periodically. We'll inflate this 100 or 200 cc's initially, and then through the skin we introduce a needle into the expander and then gradually expand or stretch this, much like a child developing in a mother's womb to stretch the skin.
How often do patients have to go back to have more saline put in to do this expansion?
Generally every week or 2 weeks, depending upon how rapidly their skin and muscles expanding. When you see them, if they seem very firm and if they're uncomfortable, you might say, we better wait a week before we put more more fluid into this implant.
How about people who've had both breasts taken off and I guess they have bilateral expanders?
And in some ways it's actually easier to create symmetrical breasts because you use the same types of expanders and expand them to the same amount, and it's easier to build 2 breasts that are the same than to match an existing breast. So,
how long after starting this procedure with the expander are the real implants put
placed
in?
Generally at least 3 months, and it will depend upon surgeon and how the patient expands. I used to like to expand patients up to the size, and I would say, you tell me when you think that either this is a good match for your opposite breast, it's a good size you would like to have this breast, and maybe we'll reduce your other breast or even increase the other breast to match it. And then once the patient said, I like this size, then we overexpand it. And the reason we overexpand it is you want the breast to have a soft and supple appearance, so you want the pocket that the implant sits in to be larger than the implant, otherwise you may have a firm breast.
Right. Okay, now, in a one-stage procedure, tell me about that.
Oh, you mean can you do this as a single stage?
Yeah.
Generally, we'll do expansion in most everybody first. Occasionally you'll have a patient where the general surgeon has not had to remove a lot of skin.
Okay.
And in that patient, sometimes you can place a permanent implant, and it can be the breast mound can be created at a single stage. You and I had talked before about an implant that we have that is post-operatively adjustable.
Right.
And I have one of those here. This particular implant is manufactured by the Mentor Corporation, and it is called a Spectrum implant. And this implant can be placed through a small incision. Has attached to it a small, what we refer to as fill tube. This fill tube is then connected to a little button or reservoir that is placed beneath the skin, generally under the arm or out on the side of the chest. And the button basically looks like this, and there's a little connector that puts these two together. With this implant, you can inflate or deflate the prosthesis and let the patient tell you when they think it's a good match. And particularly when we're doing tissue expansion, and then you think you've got everything just right, and you put an implant in, and occasionally a patient would say, well, I really want it a little bit larger or a little bit smaller. This implant gives you that flexibility to adjust post-operatively the size of the implant, and then at a later date you make a small incision over the port and literally can withdraw this fill tube, and then this is a permanent implant, so it doesn't require yet another surgical,
and this
major
is
surgical
saline.
procedure. Correct.
Saline.
This is a saline inflatable implant, yes.
Phil, can you put that picture up again of the diagram of the 3 breasts? I just wanted, the one in the middle, is that the one with the expander?
Yeah, that I think depicts the expander that is partially inflated.
Okay. All right. How long, I'm not sure whether to ask this question or not.
Oh.
But because, people don't like to hear the answer, but are these permanent? How often do they last? Do they have to be removed and replaced somewhere down the road?
Well, the manufacturers would say, just like your car or refrigerator, if it can fail, an implant can fail. Right. As I said, I've been practicing for a long time. Most patients whom I've put implants in, whether they are cosmetic, breast enhancement, or reconstruction, still have the same implants that I put in 20 or 30 years ago. However, either a saline or a silicone implant can, quote, fail, meaning that you can get a little rent, and they're referred to as fractures. If you think, I use the example of a paper clip that you bend back and forth and it snaps. If an implant, particularly the ones that used to be what we call textured, that didn't move around in the pocket, if you think of bending one little spot on it back and forth many, many times, you can eventually get what they call a little stress fracture. In a saline inflatable implant, like a balloon, a tiny little hole will leak. It's not dangerous to the patient in the sense it's sterile saline, IV fluid that we use, but they have the inconvenience, of course, of losing their reconstruction and have to have that replaced to maintain.
Right. If you do the implant on the affected side, but you also add an implant on the unaffected side for balance.
Right.
How does that affect mammograms down the road?
It is fair to say that anytime you place an implant, it makes it a little bit more difficult to do mammography. It is my understanding from the literature that implants, they may in certain cases delay diagnosis, but it's also my understanding that they don't affect patients' longevity. The long and the short of it, our mammographers would tell us, anytime you add something else, it makes my job harder, and I believe that.
Right.
But the risk to patients of having an implant, either for reconstruction or for just breast enhancement cosmetically, is very minimal.
Do you want to show your other implants? I really don't want to miss showing those, because people wonder what these things...
And I'll just remove these because they get confused. But the types of implants, we had talked about saline or silicone implants. Right. Both are available to us today. They have both advantages and disadvantages. This is a silicone implant that I'm holding here. It has what's referred to as a cohesive silicone, so that if we cut it, it wouldn't leak out like a syrup. On the other hand, this is saline. It's like water. And one of the disadvantages, particularly if you had a very slender patient and the implant was placed just beneath the skin and not underneath the muscle, is what's referred to as rippling. If I hold this up, you can see kind of little curves here. Now, because we put most of these implants beneath the pectoralis muscle, and if you support the implant just a little bit, the rippling is diminished. So we rarely see it in the implant placed beneath muscle. And in the case of breast enhancement, we virtually always recommend putting it beneath the muscle. The gel will do that a little bit, but not to the same degree. You can see fine little wrinkles, but if I hold the both up, I think the saline should produce more waviness.
You know, as opposed one to the other, there's not a lot of difference in feel, although you did say that you felt like the gel.
See what you think. The gel is a little more, I think, elastic. If you place these implants beneath both the skin and the muscle, it's reasonably difficult to tell the difference. Unless you were, it's going to sound silly, used to examining people, you probably wouldn't be able to tell the difference.
Now, this is a really stupid question, but I have to ask it because there's somebody out there thinking about this. The gel-filled one, the saline-filled one, with movement, can you hear anything slushing?
Good question. Sometimes when we first do these, because these are filled intraoperatively, and we try to remove all the air. if you don't remove all of the air, it will come through the membrane. So it eventually, and by eventually a couple of days, it'll be gone. But just like if you had a container not completely filled, you could hear that.
Something slushing.
The other thing that happens is immediately after surgery, there is fluid in the pocket where the patient has their implant. And I've had more than one person call me and tell me their breast was making a noise. And what's probably happening is as they move their arm and their muscle flexes, the fluid that's around them is being squeezed from one part to another, and it makes a noise. Because I've had people put the phone up, and I explain to them that that's not a dangerous thing, and it'll go away, but it's disconcerting when you start having a musical breast, so to speak.
And during a hymn in church, maybe.
Right. Unless you're in tune, right?
This is a whole new thing you could offer, musical breast as part of the service. Okay. In women of childbearing age, who have experienced breast cancer and had to have an implant and then another implant for balance, how does that affect breastfeeding if they want to do that?
Right. Again, my understanding, and there have been lots of studies and reports, that it's perfectly safe for women either with silicone implants, the gel implants, or the saline implants to breastfeed. Some people have done studies and have told us that you actually ingest more silica if you use a glass bottle. Glass is made out of sand. Silicone is made out of sand. So it's a relatively inert substance, and that the data would support that women who breastfeed, who have implants, do not put their child at increased risk.
Okay. Now, people may not be aware that with most, I guess all mastectomy procedures for cancer, you lose your nipple. The nipples are lost. Is there a way to reconstruct a nipple or to give back that appearance of normalcy?
Right, and I would agree with you. Rarely, but occasionally, we'll see what's called a nipple sparing procedure.
Right.
Lesions that are close to the nipple, you always or most always would want to remove the nipple because the ducts where the breast cancer starts go all the way up to the tip of the nipple. So that's one of the reasons that the nipple is removed in lesions depending upon their location. Your question, can you reconstruct a nipple and areola complex? The answer is yes. We reconstruct the nipple using what are called little flaps. We use a flap that is called without diagrams, they're hard to explain, but what's called a skate flap. So basically, we're trying to produce a nipple projection, and these little flaps do a very nice job. And in the past, we would take skin grafts, and we would try to find skin grafts that might match the skin color, whether someone is white or Afro-American, etc. But now, more commonly, the areola and even the nipple is pigmented by tattooing it. So we use pigment that would either match the opposite breast, or patients we have it's like the paint cards you get. You'd say, what color do you think it would look best on you if you're doing bilateral, or what would match your previous areolar color? And then that is tattooed into the nipple and areola complex.
I have heard of women having stars and hearts tattooed as nipples. Do you see that often?
I have not done that. I'd be afraid I would mess it up. And I did have one person who wanted me to put a little heart, and I said, I'm just not comfortable doing that because it might not turn out to be a nice heart.
In having dealt with breast cancer myself, I do know that if you have the ability somewhere along the way through this process to laugh, it really is a healing thing to be able to have a sense of humor as you approach it and deal with it.
And because we see our patients over time, over a long period of time, we get to know them pretty well. And I agree with you, most people are looking towards the future, the rest of their life. And once they get over the initial shock and then they want to move on with this and get on with their life. So, and I think being their friend and particularly people who really enjoy humor, I think it's a good thing also.
If you were asked by a woman to tell them, someone who's facing mastectomy, and are concerned about how they're going to continue to feel and look and be feminine, what would you tell them?
Yeah.
Bad question.
That's a tough question. And I would tell, I don't know if I would tell them this at the time, but a woman who feels good about themselves before a mastectomy, I think, can virtually always feel good about themselves after. If someone has a poor self-image before, it's going to be even harder, I think, for them to feel that way. I think support of their loved ones, their spouse, their significant other is very important. My experience has been most often the individual feels worse about themselves than the people who really care about them. It's not such an important thing, but it is very important how you feel about yourself.
It is.
And I think when people stop taking care of themselves, stop caring for themselves, it's a bad sign. So I think it is a better sign when people say, no, I want to look as good and feel as good as I can, and because I've done this, it makes sense to me why a woman would choose to have breast reconstruction.
And you know, I think the hair issue with chemo, losing your hair, I mean, that's so devastating because all of a sudden, you know, you've lost the sense of who you are, and that's in your face every time you look in a mirror.
Yeah.
So I do think that anything that you can do as you're recovering from this, going through this process, to make you feel better about yourself, to feel more like yourself. A friend of mine told me, she said, hey, she had the flap procedure and tram, and she said, hey, I'm getting a tummy tuck. I'm going to look better than all of you all in a bathing suit. So, you know, I think that's such a positive
My
thing.
sister is a breast cancer survivor, and she went through both radiation and chemo, and she has 2 sons and a daughter, and when her hair was, I mean, it just, one day, just about went in. And her son said, Mom, we're going to shave heads too. She said, why don't you not do that? I don't want to look at your bald heads. But she really appreciated the fact that they were supporting her. But she said, I think maybe I can look at one person in the mirror and that'll be enough.
Well, I thank you so much for doing this and for sharing this information with people who may not be aware of what their options are. And maybe this will take some of the fear out of going and getting themselves looked into and doing regular mammograms and stuff, because, you know, there is life after breast cancer.
You know, and I think most people don't want to deal with or confront these things, but just hearing that these things are possible in the event that I have to confront them, because what percentage of women is it? 8% of women over their lifetime.
Yeah. It's 8 out of 10 women.
Yeah. Oh, it's that high.
It's that high. Yeah.
Anyway, like men, prostate cancer, we don't want to think that it might happen, but
it's there.
If we live long enough, it's there, yeah.
Thank you, Tim. I appreciate it so much. I hope you've enjoyed tonight's show in this 2-part series on breast reconstruction. Throughout October and Breast Cancer Awareness Month, please make an appointment to get a mammogram if you are due to have one and have not taken that step. Continue to do breast self-exams. Mammograms do save lives. As of last month, I'm a 4-year breast cancer survivor. So go out there and take this bull by the horns and take your future in your own hands. My next show will feature the Amazement Square. Thank you so much for watching. Have a wonderful evening. Good night.